Well, let me just begin by thanking the organizers. It's really a pleasure and a privilege to be on this wonderful program. It's been a very good day so far. Just some disclosures. We've been fortunate to receive funding for our research and the activities of our lab from several organizations, the National Institutes of Health being the leading organization. And so in terms of what I'd like to talk about, I've organized this and we'll be very brief on each of these points. I'll talk a little bit about how I think about language and its development in children in general. Then we'll talk about some of the facts about language development in individuals with intellectual disabilities with an emphasis on those with Down syndrome. I'll talk a little bit about measuring language development and intellectual disability in a general way before I focus on a particular set of procedures that we've been developing in our lab called expressive language sampling, which I think has real potential for clinical assessment in a variety of settings, including in clinical trials, which we're involved in right now. And then I'll use that as a way of also showing you what we've learned using this procedure about the language phenotype of individuals with Down syndrome, talk a little bit about the psychometrics of this expressive language sampling procedure, and then if there's time, some additional measures that we're developing. And then I want to just end by talking about what I think is really critical is measuring language in clinical trials. So let me just begin with probably a pretty obvious claim. Language is not a unitary ability, and what I mean by that is that language can be dissected into distinct and interrelated components or skills or patterns of behavior. So we can talk about vocabulary as a separate component, and syntax as another component, phonology, or the ability to master the sounds of one language. Or we can talk about genres or types of talk, types of language. We can talk about storytelling versus conversation. And we can talk about kind of patterns of behavior that are atypical or maladaptive, like perseveration or echolalia. And making those distinctions are important because clinically we know that different children will show different profiles, and those might be related to etiology. So some children may have more trouble with syntax than with vocabulary and so on. So these are really important functional distinctions. So learning and using language are embedded in and dependent on other social, cognitive, affective, and motor activities. And we can talk about these as the foundational domains. One needs to have some oral motor capabilities in order to produce any language. One needs to have some level of cognitive development in order to have something to say, or have a certain level of memory in order to understand, in order to kind of hold in mind what one hears so you can analyze it and determine how to produce it yourself. So linguistic achievements then can be limited by these impairments in foundational domains. So for example, some of what we found in atypical populations is that auditory short-term memory, the ability to hold sounds in memory for a while is a predictor of language impairment, language growth. The presence of maladaptive behaviors or mental health conditions also affects language development and the use of language. And so we know that anxiety, for example, interferes with learning language because it leads to withdrawal from social interactions, and also it leads to problems in planning utterances and the like. And so I just want to make a couple of points about language development and intellectual disability in general. This is a study that we conducted some time ago, and this is with teenagers, so adolescents with Down syndrome, adolescents with Fragile X syndrome, and typically developing children. And the adolescents with Down syndrome and Fragile X syndrome were selected so that they were matched on their nonverbal IQ as well as on their age. So they're very comparable except in terms of etiology. And we compared them to younger, typically developing children, so 3 to 6-year-olds who had the same level of cognitive development. And we do that in all of our comparisons, not because we think an adolescent with Down syndrome is the same as a 3 or a 6-year-old typically developing child, but if they're equated cognitively, it allows us to have a benchmark so we can determine how impaired is language relative to cognition. Because we know, based on everything we know about language development, that if you have cognitive impairments, language will also be impaired. So it's not a particularly interesting question to say, is a child with Down syndrome delayed in language? We know they will be, but how much relative to what their cognitive skills are? And so we make these comparisons. And this is a particular test called the TACL-R, which stands for the Test for Auditory Comprehension of Language. And it's a commonly used test by speech-language clinicians. The child hears a word or a phrase or a sentence and then points to which of several pictures matches the meaning of that. And it's broken into 3 different subtests. There is essentially a vocabulary test, which is represented by red bars, and then there are 2 syntactic tests. One that focuses on grammatical morphemes, and those would be things in English like adding a past tense or plurality, those little markers we put on words to give a more nuanced meaning. And then these green bars are essentially understanding kind of the syntactic rules, or how words combine into phrases and sentences, and higher bars indicate better scores, better performance. And so what you can see in this study, and others have found this as well, is that individuals with Down syndrome do as well in terms of their vocabulary as do individuals with Fragile X syndrome, and as well as typically developing younger children. So they're still delayed, but they're delayed at about the same level we would expect given where they are cognitively. But that's not true for syntax. Individuals with Down syndrome are more impaired in the syntactic domain, so learning how to mark words for plurality, for past tense, learning how to use order to convey meaning, and so on. And they do more poorly than that do individuals with Fragile X syndrome. So this is just a way of pointing out something about variability in language. There's a variability across ideology. We know there are differences across these ideological groups, even though they're all associated with intellectual disability. And then we know that there's variability in terms of the domains of language. So we see, in the case of Down syndrome, much better performance with vocabulary than with syntax or grammar. This is a slide from a study of a former colleague of mine, Robin Chapman, who's done a lot of research on Down syndrome. And this is individual growth curves for children and adolescents with Down syndrome who were studied over a 6-year period. And they began the study anywhere between the ages of 5 and 15 years, and then they were studied for 6 years. And each of these reflects a change over time for an individual. And the particular measure is mean length of utterance, MLU, which I'll talk a little bit about. And it's just kind of a gross measure of syntactic complexity. So basically, the longer one's utterance, the longer one's phrase, the more complex it is, the more you know about the syntax of the language. And so again, getting longer utterances reflects growth. And one of the things that you can see here is that there's variability with age. In general, people are improving with age, although at different rates. And then there's a lot of individual variability in terms of these intercepts. Okay, so there's variability in age, and then there's within syndrome variation as well. And so in terms of what we want for to understand about Down syndrome, and I haven't shown you all the data on these, but we know that Down syndrome variation in language development is related to age. There's variation related to age. We know that there's variation related to nonverbal mental age, so a measure of kind of general cognitive capacity. We know that auditory memory is related to, so better memory, auditory memory is associated with better language. Hearing status, more severe hearing impairments is related to worse language and language growth. And then maternal education also determines the growth in language. And there are a number of studies listed here that summarize those claims. So in terms of measuring language development then, there are several requirements, and I'll talk a little bit about each of these as we talk about expressive language sampling. If we want to develop a new measure of language, we want it to capture variation in ability across multiple domains of language, because not all language is equal. Some children may have vocabulary problems, as we've seen in Down syndrome, that are less severe than in the syntactic domain. In addition, one would like to have a language that is applicable across a wide range of ability levels and ages. Right, and that's one of the challenges as we do clinical trials, as you talk with pharmaceutical companies, that they would like to enroll into their trials people that go all the way from age 6 to age 20, and they want one test to measure everything. That's very difficult to do. But to the extent that we can do that, then I think we're really facilitating treatment research as well as research in general. And then obviously you want your measure to have strong psychometric properties. So we've been working on something called expressive language sampling, and we certainly did not invent this. This has been around and used to understand language development in typical children since really the early 70s. Roger Brown at Harvard really pioneered its use. But what we've done is kind of try and standardize it more for use in research, and in clinical assessment. I'll tell you a little bit about that. But the basic idea is what you want to do is you want to set up a situation in which a child talks, and you want to make it a relatively brief interaction, because we don't have that much time to do an assessment, but you'd like it to be representative. So you would like these samples to be representative of the child's expressive language capability, whether that's vocabulary or syntax or pragmatics, the ability to use language for social ends. And so what you do in this is you collect these language samples that you want to be representative, and then you transcribe and analyze them for a range of components and skills and patterns of behavior. So you can transcribe them and then analyze them for their syntactic complexity, or for the diversity of their vocabulary, or for whether they involve particular rates of echolalia and the like. So it turns out, and I'll talk a little bit more about this in a second, so doing this, collecting these samples in a brief way to make them representative is not that difficult to do if you just spend a little time. The transcription and the analysis is actually very time consuming. That is becoming less and less problematic because there are more and more automated sorts of programs that facilitate that. We use something called SALT, which stands for Systematic Analysis of Language Transcripts, that essentially computes all of the measures that I'll talk to you about automatically, so you don't have to do it by hand, but you still have to transcribe the language in a very painstaking way. And for children with Down syndrome, that transcription is made even more difficult by their difficulty with intelligibility, right? They have speech articulation problems, so it's often difficult to understand what they're saying. What I'd like to claim is that if you do this in the right way, you have in relatively brief assessments, but you can make very robust inferences about language ability across groups, clinical groups, across individuals, or across the same individual assessed on multiple occasions. So one of the challenges, though, in using this expressive language sampling procedure is that the representativeness of the sample you gain can be influenced by lots of different things. The materials you use that are the focus of the talk, the behavior of the partner, and the particular genre or the task. So do we have any speech-language pathologists here? Any speech-language clinicians? No. Okay, so let me just give you one example. If I'm talking to a child, and what I say to the child is, what color is this? Do you like this one? Does this jump? Is this a train? What will I get from that child? Will I get a rich, representative sense of his syntactic capabilities? No, I'm going to get one-word answers. And so I'll conclude this child has very limited language because I forced it with how I've interacted with him. The same is true with the materials, and the same is true with kind of the nature of the talk, whether it's embedded in play or whether it's embedded in conversation or book reading. And so there are 2 points to make here. We really need to standardize the sampling procedures, and we need to sample multiple genres or tasks. We need to assess in multiple contexts and put it together to get a complete picture of what the child can do. So what we've done, and this has been, I think, our contribution, is that we've tried to standardize the procedures for sampling in 2 contexts, or 2 genres, conversation and narration. And I put standardized in quotes because it's not standardized in the sense of when we really think about something like the Stanford-Binet test, for example. And what we've done is we've standardized the topics that we introduce in conversation. We standardize a storybook that we use as the basis for the narrative, for the storytelling. We have the examiner's practice, so their behavior is highly scripted, so that they introduce topics in exactly the same way across children, that they respond in particular ways, and so on, while still being natural and conversational. We've also created alternate forms, so there are A and B versions of each task so that you can use that different versions as you do longitudinal work or clinical trials and look at pre and post. And it's reasonably quick, so 10 to 15 minutes for each of these activities. And just to give you a sense of it, in conversation we might introduce a topic, something like, what did you do after school yesterday? Tell me everything you did. And then as the child talks, you can prompt in particular ways. In narration, we use wordless picture books. Like many other child language researchers, we have made Mercer Merrick quite rich because we buy all of his books and use them. And they're really great books because it turns out they're very interesting for young children as well as for adults because they have very detailed drawings with lots of different ways of talking about them. And so here are some of the things that we have found using expressive language sampling procedures. And again, mean length of C unit, don't worry about that too much, but it's just a measure of the length of the utterances that the individual produces, and the idea being longer utterances reflect greater linguistic capability in terms of syntax. And again, these are all groups of individuals that are matched on nonverbal mental age. And what we found here, which other people have found as well, is that both individuals with Fragile X syndrome, but particularly individuals with Down syndrome, are really impaired relative to these younger, typically developing children who have the same cognitive level. So their syntactic capabilities are more impaired or lag behind even where we would expect based on their general cognitive ability. And we see differences between conversation and narration. This is just another measure using, in this case, we're only using narration. And there's something called developmental sentence scoring, and it's a more sophisticated, more nuanced way of looking at syntactic complexity. And what one does is you kind of code for each of the features of syntax that you would expect the children. So if they use past tense, they get a point. If they use plurality, they get a point. If they use two verbs within in the same sentence, they get a point, and so on. And what we found is that in this case, both individuals with Down syndrome and individuals with Fragile X syndrome were impaired relative to where we would expect them in terms of their nonverbal cognition compared to these younger, typically developing children. Then this measure reflects whether the utterance, independent of its complexity, is grammatical or not. And what we found there is that individuals with Down syndrome are more likely to produce ungrammatical utterances even than individuals with Fragile X syndrome. Okay? This is a measure also derived from language samples here, conversation and narration, where we're interested in their vocabulary. So just the diversity of the vocabulary they use. So higher means more diversity. And again, what we found was that the typically developing young children had more diverse vocabularies than adolescents with Down syndrome. So again, impaired not just relative to their chronological age, but also relative to where they are in terms of their nonverbal cognitive levels. Speech articulation, this is just a very gross measure of articulation ability. It's the percent of utterances that were produced that were unintelligible to a transcriber, a trained transcriber. And so here, higher numbers indicates greater problem, not superior ability, but greater problem, higher rates of unintelligible utterances. And what we found in this study was mainly focused on individuals with Fragile X syndrome, but what we did find is that, as expected, we saw relatively high rates of unintelligibility of speech articulation problems in individuals with Down syndrome, not in individuals with Fragile X syndrome, unless they also met criteria for autism. And so these subgroups were very different. And I think this is an important one to show, because in most of what we find, we continue to look for where individuals with Down syndrome do worse. And it's very difficult to read, and so I just want to make a couple of points. This is, again, comparisons between individuals with Down syndrome, Fragile X, and then younger, typically developing children. And we rated different elements of how you tell a good story, whether you introduce things appropriately, whether you talked about the characters, mental states, whether there was cohesion and the like. And in this case, what we found is that individuals with Down syndrome actually did better than the typically developing children. They're still delayed relative to their age, but their stories are richer on at least some dimensions like cohesion. They're kind of tighter, more cohesive stories. And overall, their stories were better. So, just to summarize what we've said so far then, is that if you use expressive language sampling procedures in the way that I've described, you can distinguish between individuals with Down syndrome, their phenotypes, from Fragile X syndrome, and from typically developing peers. We saw in the case of the intelligibility measure, you can distinguish between subgroups within a syndrome. And we can look at multiple dimensions of language behavior from the same samples. We can look at vocabulary, intelligibility, syntax, and many other things that I haven't had time to go into. It's relatively simple to collect. And the downside is that it's labor intensive in terms of transcription and coding, but again, that's becoming increasingly automated. And then one of the questions that I haven't addressed to this point is kind of how adequate the psychometric properties are, and I'll turn to that now. So this is just a small study that we published a couple of years ago, where we wanted to get a sense of the psychometric properties of this. And this interest was really driven by the need within clinical trials to have better outcome measures. I think there's a feeling in general in these pharmacological trials that we have drugs that have good potential, but we don't have measures that are really sensitive to change, and so we run the risk of essentially throwing out drugs that are efficacious because our measures are not sensitive enough. And the NIH, and you'll hear more about this tomorrow, has really invested, the National Institutes of Health in the United States has really invested in helping us develop better outcome measures. And so this was a small pilot study in that vein. We were really focused on test-retest reliability over a very short period, 2 to 3 weeks. We also, in a very preliminary way, looked at kind of measures of external validity. We looked at correlations with the Vineland Adaptive Behavior Scales. And we used a trained novice as the examiner. This was a first-year medical student who, other than babysitting once in a while, had no real experience testing children, because we thought it was important that we could show that we could train anyone to do this if they were careful enough. And we were. In this study, it was only individuals with Fragile X syndrome, 25 males, 11 females, a very wide age range, as you can see. And one thing to say is that virtually all the participants completed both our conversation task and a narration task. I think out of the 36 individuals, there were only 3 individuals that were non-compliant on one of the tasks. So virtually all of them completed it in a meaningful way, which is really important, obviously. And so these are just to show you the means, and so let me just mention what each of these is. This is the total number of utterances in the particular time frame, so it's a measure of talkativeness. Here again is mean length of utterance. This is a measure of the syntactic complexity. This is something called the utterances with mazes, and so higher numbers are more problematic. So mazes would just be disfluencies that are reflective of problems in planning and execution, and so if you had lots of ums and ers. I went to the store. Those would be mazes, and they reflect difficulties with planning. Here is the unintelligible utterances, which I've already mentioned, and the number of different word roots, which I mentioned previously, is a measure of lexical diversity. And so these are the means from the test and the retest, and then we used interclass correlations, which really are designed to determine whether the variations is related to variations in subjects or on testing occasions. So you want these numbers to be quite high and as close to 1 as possible. And you can see that for conversation, when we look at short-term test-retest reliability, it's very, very good. So individuals are getting essentially the same scores on repeated testing. And if you look at that in terms of the means, there really is no practice effect, which again, if you're going to do a clinical trial, you want to measure that is stable over repeated testings over the short term, because you don't really expect developmental change in the absence of some kind of intervention. And so those data were very encouraging to us. These are the same data for the narration. So this is for doing the wordless picture book. The interclass correlations are not quite as good, but they're all highly significant and again, encouraging. And again, very little evidence of any sort of practice effects. And so again, this was very encouraging to us. Here are some correlations. We looked at the bivariate correlations with different measures that we thought should be correlated from the Vineland. There are not lots of correlations, but there are at least patterns that are sensible. Mean length of utterance, that syntactic measure, tends to be one of the best in terms of correlations. We see more correlations with expressive language and written language than receptive language, which also is sensible. If you look at narration, it's a little bit better. And again, mean length of utterance correlates with a lot of these, all 3 of these scales and so on. So again, these are not overwhelmingly encouraging, but at least they suggest that there's something that correlates in a way that suggests that we're measuring similar constructs in these different measures, and we're continuing to look at that. So what we can conclude from the data that I've showed you from this very admittedly small scale study is that these measures are quite feasible for children, adolescents, and adults with Fragile X syndrome, and also individuals with Down syndrome in our more recent work. We saw in this particular study excellent test-retest reliability, very minimal practice effects, essentially no practice effects, and some evidence of the construct validity, although the Vineland may not have been the best measure to use for that. The other nice thing that I think is really important about these expressive language sampling procedures is that in theory, although our study was done obviously with native English speakers, that you can use these same procedures across dialects across languages and across cultures. And so they, right now, are really only limited, and from our lab, by the fact that we don't have Spanish speakers or French speakers in our lab, but the procedure should work just as well. And in fact, many child language researchers in many countries, at least in Western Europe and beyond, have used expressive language sampling procedures, so I think it has great potential. Some of our next steps that we're doing, and this is with funding that we have received from the National Institute of Child Health and Human Development. In one of their calls for proposals, we were lucky enough to be funded. We are extending the psychometric study that I described to a larger sample and including individuals with Down syndrome, so we can begin to understand whether this works as well for individuals with Down syndrome as Fragile X syndrome in terms of the psychometric properties. We are expanding our psychometric analyses. We're doing more test reliability, better measures of validity. We're looking at sensitivity. We're looking at, and I think this will be very important, we're looking at the psychometric properties as a function of characteristics of the participants. So do the psychometric properties work? Are they stable across ages? Across ability levels? I think our early findings from conversation and narration so far are suggesting that for children with Down syndrome that get below the age of 7 or so, these procedures don't work very well. They're too demanding. They're not context-bound enough. But for individuals above about age 7, it works quite well. The other thing that we want to look at is, so I mentioned that each of these tests takes us about 10 or 15 minutes. Many of you, if you're doing a large battery, even 10 or 15 minutes to put together for 20 minutes to 30 minutes is too much, right? And so one of the things that we're looking at in this study is how large do the language samples really need to be in order to make good inferences about language ability without impacting in a negative way their psychometric properties. And so we're beginning to look at that. The other thing, as I mentioned, we don't think this, even though these procedures work quite well across a very wide age range and ability level range, they don't work for everyone. And so we're looking at two different ways of collecting these language samples to see if they work for younger children. One of them is just structured play, so play with toys, but in a particular way with particular scripts and particular toys. And then we're using the ADOS, the Autism Diagnostic Observation Schedule, which people are using to diagnose autism, and they've suggested that as long as you're diagnosing autism, you can use the language produced as a way of kind of making inferences about language ability, and so we're looking at that as well. The other thing that we're doing in our project that's funded by the NICHD is we're looking at can you do this across multiple sites? Can you train people to do this across multiple sites at a distance? Can you, will they yield the same sorts of conclusions across sites, or does it really require kind of hands-on training and supervision? And so far, we think that you can do this quite easily at a distance. And then we do have plans to extend to other languages. In fact, we are ready to submit a proposal to the NIH to do this in Spanish as well. So I just want to briefly mention that we have two other measures that we're developing to look at language. And I won't tell you anything about the graph, I'll just mention what the procedure is. One of the things that we're very interested in, particularly from a clinical trials perspective, is measuring learning in real time. So even our expressive language sampling is kind of a static measure. A standardized test like the Stanford Binet is a static measure. It measures what you've learned up until that point. And what we really want to impact, whether we're doing a behavioral intervention or drug intervention, is that we want to improve the way that learning occurs. And so we have developed something called fast mapping, which is a procedure that essentially introduces an opportunity to learn new words and what they mean, and then study the process, how much support the individual needs, the cues that they use or don't use to learn, and so on. And we've been able to begin, at least to begin to show that it has good psychometric properties, that it distinguishes between different etiological groups as well. And then we have another procedure that we're developing, and this is for older children. It's called comprehension monitoring. And it's one of the things that you may be doing now, given that I've talked fast, especially near the end, is you monitor whether you're understanding or not. So you know if you have processed it, if you understand it. If you don't, You can decide that you can ask a question later on, or that, well, maybe you don't need to understand it anyway, but you pay attention and you monitor your comprehension in real time. And so we've developed a procedure to do that in younger children with disabilities, because we think it's a real problem in academic settings where they're not monitoring their comprehension and they're not indicating when they have a failure in comprehension so they can get more information. And we've developed a task that works quite well for that. So the last points I'd like to make are about using language in clinical trials. We think that it's really important as we search for, right now, the drugs that are being tested for Down syndrome and for Fragile X syndrome and for autism are really expected to have kind of pervasive effects, or we don't know exactly what the effects are going to be on the brain and how that will translate into specific behavioral manifestations. And so there's a lot of concern about what to measure. We think language is a very important thing to measure in clinical trials because it's meaningful and it's functional. If you can improve language through an intervention, you have really opened up that child's world. Their adaptive behavior is better, their ability to interact with others, their ability to learn in academic settings is improved. So we think measuring language is really meaningful and functional. Moreover, language can improve for a number of reasons, and therefore you can impact it and lead to improvements for lots of different interventional reasons, or through lots of different kinds of pharmacological treatments. Language can improve because you've learned new things about language, new words, new ways of combining words into phrases and sentences. You may have better language, not so much because of the language, but because your memory is better, or that your hearing is improved, and so on. So these improvements in foundational domains can also lead to improvements in language. So if you have a drug that, let's say, improves memory, language may show that. In addition, reductions in maladaptive behaviors and mental health symptoms can lead to improvements in language. You reduce anxiety, language output is better. And so we talk about that as improvements in language. They reflect new learning, that you can learn new things in language, or that old constraints have been lifted. So anxiety no longer is a barrier, and so on. So we think that this is really an important thing to develop for clinical trials, and in fact, when I listed the disclosure, you notice that there were 3 drug companies. All 3 are now using expressive language sampling as a secondary endpoint in their clinical trials. 2 are trials with Fragile X syndrome. 1 is a very large, a multinational study in Down syndrome. So we're very pleased about that, and we hope that it helps to show whether these drugs are efficacious or not. And so thank you very much. It's really been a pleasure to be here. It's been a great day. You've all been good sports to stay here this long and listen to the very last talk, so I do appreciate that. Thank you very much.